Thank you everyone for joining for the Mary Seeman Lecture. I do want to start with the land acknowledgement. I would like to begin with acknowledging the land on which we work, study, and live. Before I read it, I want you to take a moment to situate yourself and think about the land under and around you. We recognize many indigenous nations have a long-standing relationship with the territories upon which the sites of the Department of Psychiatry are located that precede the establishment of the University of Toronto. We acknowledge our presence on the traditional treaties of many indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat people. Today, this is the land is home to many diverse First Nation, Inuit, and Métis people, and we're grateful to have the opportunity to live, work, and gather in these territories. We acknowledge that Toronto is covered by Treaty 13, signed by the Mississaugas of the Credit, and the Williams Treaty, signed by the multiple Mississauga and Chippewa bands. Since this is a virtual gathering, a singular land acknowledgement does not fully capture the richness of our tradition across many locations. There are many places, there are a few places on earth that somebody before us has not called home. Maybe while we wait, maybe I'll say a little bit about Dr. Mary Seeman. I really want to mention condolences to Dr. Mary Seeman's family. Unfortunately, she passed away a couple of days ago, and it's a great loss to our community here. And she was a pioneer in so many ways. I just want to read a little bit from her obituary. She's Professor Emerita for the Department of Psychiatry at the University of Toronto, who's worked to deepen our understanding of schizophrenia. As the inaugural Tapscott Chair of Schizophrenia Studies, she led research and revealed the biological mechanisms of underlying psychotic drugs, antipsychotic drugs, informing drug development and guiding the treatment. Her research into gender differences in schizophrenia shaped treatment guidelines and opened new avenues for clinical research. Mary helped bring the benefits of her discoveries directly to patients in establishing the first outpatient clinic dedicated to women's mental health at CAMH. In addition to her prolific academic publications, she wrote about schizophrenia for the general audience as well. She served as the head of the active treatment clinic at the Clark Institute. She was also the president of the Ontario branch of the American Psychiatry Association. As mentioned, a huge legacy that she'd leave in the Department of Psychiatry and so many members that she touched. And I just want to acknowledge that and deep condolences to the family. As I mentioned, there'll be evaluation link sent at the end of our session as well. Julio, if you can put the slides back up, please.
Can you see full screen now?
Yes, if you can move it down, please. Yeah, so as Dawit is going to be speaking about the Mary Seeman Lecture. Next slide. Next slide, please. The next citywide psychiatry grand round is going to be on gender dysphoria. It's going to be by Dr. Lam and Dr. Basie, and hopefully you'll join us for that on May 31st. You can take down the slides. Thanks, Julio. Julio, you can take down the slides. So without further ado, I would like to introduce Dawit Wondimagegn, from Associate Professor from the Addis Ababa University. Dr. Wondimagegn was the former Chief Executive Director of the College of Health Sciences, Vice President of Addis Ababa University, Chair of the Department of Psychiatry, and Director of their graduate program in the past. Currently, he's Associate Professor there, a consultant psychiatrist, Director of the Addis Ababa Academic Collaboration, and the National Lead for the African Health Observatory Platform, Ethiopia National Center. Though his numerous activities as a clinician and health systems leader, global mental health expert, IPT expert, and researcher, he's helping to decrease stigma and improve access to mental health care. He co-leads the Marcy Rose and Addis Ababa academic collaboration to develop postgraduate subspecialty training programs in numerous areas of medicine, primary care, and nursing in Ethiopia. He's published in the areas of global mental health, family medicine and medical ethics, psychotherapy, knowledge translation, post trauma, depression. He was the primary investigator of 2 Grand Challenges Canada-funded projects, the Biaber Project to scale up screening and mental health care in Ethiopia in the primary care settings, and to engage Ethiopian standard healers using collaborative models to increase the identification and treatment of psychiatric disorders. He culturally adapted IPT to Ethiopia and led IPT workshops for psychiatry residents at the Addis Ababa University and the University of Toronto. The Biaber Project has enabled training of over 500 Ethiopian primary care nurses in IPT-E. Without further ado, I would like to welcome Dawit for presenting today the Mary Seeman Lecture. I'm so grateful that he could speak from Ethiopia today, sir.
Thank you, Raj, for a very kind introduction. I would like to thank the Department of Psychiatry at the University of Toronto for extending the invitation to speak at this distinguished event. I would also like to...
Dawit, I'm sorry. Can you put it on slideshow or presentation view?
All right.
Thank you.
Okay. I would also like to note that opening up spaces for views and perspectives from people from other cultures is a commendable stance that demonstrates both openness and commitment to the task of diversity and inclusivity. So I would like to note that the department has done that just by extending this invitation. I recognize that I'm doing this lecture the memory of now of Dr. Mary Seeman, who just passed away as communicated. And I would like to pass my condolences to both the family and her colleagues at University of Toronto, but also globally. I think that from her contributions, an icon is lost from the global mental health community. I would like to acknowledge and recognize the contribution of the leadership and faculty at the respective departments of psychiatry at Addis Ababa University and University of Toronto for their various contributions. You may recognize some faces here through the Toronto Addis Ababa Psychiatry Project and the Toronto Addis Ababa Academic Collaboration. As this presentation is one of many outcomes of our relationship. The brief outline of my presentations looks like this. I'll talk about mental health care in Africa and then our experiences in psychotherapy adaptation and some reflections and recommendations. I chose the topic of adopting and adapting, exporting Western psychotherapies for this talk. The importation and adoption of psychotherapy is bound by the historical and current realities of our time and Africa. It is the nature of our time to live with polarizations where forces claim only their reality and positions are valid, and attention to negotiation and recognition of others, alternatives, or difference is increasingly absent, perhaps especially from the middle of things where life happens. Remember, I am an Ethiopian, and Africa has much experience of this. When we look at the historical realities of the development of mental health services, in Africa, we find that it followed the paths of Western medicine. As Max Weber said, Western medicine is an imported or imposed science for non-Western cultures. So is mental health science and practice. In a recent paper, we reported the historical development of mental health services, education, and research in Africa has followed these two paths of importation and imposition. Mental health services in Africa were set up by colonial institutions. After the geographic decolonization process was completed, these institutions continued with structure and function unchanged. Since most of us with mental health background struggle with geography, this is Africa. Green is mostly the east, that yellow is north, blue is west and central and South Africa. And we'll be using this map to guide our discussion. In Ethiopia, for example, where there is no direct colonial history, mental health services developed from indirect colonial pressures and internalized assumptions that imported Western ideas and structures were superior. In North Africa, psychiatry was developed not only as a medical science, but as one of the weapons, that is a quote, in the arsenal of racism and a way of negotiating citizenship. If you read Colonial Madness, Psychiatry in French North Africa, you will see how race and racism is used in the struggle towards liberation. In fact, most of the work of Frantz Fanon was informed by his direct witnessing of this dynamic at play. And in West Africa, that is the blue there, as well, psychiatry developed through the asylum system with specific conceptualizations of the African mind, as that is that of a primitive African mind. While Northern West African developments stem from the perspective of dealing with primitive madness, in East African countries, it developed as a way of dealing with problems of crime and disorder. So Ethiopia is at the top of the greens there. It has never been colonized, but in the rest of the Eastern African colonies, again, reading the literature there indicates that mental service developments came as a result of controlling crime and disorder, not with the intention of treating the mentally ill. As most low-end middle-income countries have scrambled to try and keep with the rest of the world, it is perhaps inevitable that they have continued to seek the adoption of Western institutions, such as education and health, that were effective in facilitating the formation of modern high-income country societies. As such, many countries in Africa have turned to importing Western education, either through sending their youth for training abroad, most of whom won't return, or inviting Western educational institutions and teachers to teach in newly formed African institutions. However, all teachings of mental health in Africa that we are aware of uses Western mental health theories of pathology and treatment, therapy manuals, teaching videos. This process have facilitated the spread of Western models of mental health training and services to the region. Now, the question is, why is this a problem? We know that there are effective ways of treating mental illnesses, and then we know how to deliver them. If we make those available whether through importation or imposition through coloniality. Is there a problem? And I think that's not where the problem is. I think this on its own might not be a problem if the foundation of mental health knowledge were truly universal and their assumptions of society globally applicable. However, when the epistemic status of mental health knowledge is not well defined and its practice dynamic, the translation of such a knowledge base across cultures remains problematic. As you can imagine, and as you know, the epistemic status of psychiatric knowledge, even in the West, is not crystal clear. It's not defined. It is in the constant stage of change and flux. So while the very nature of psychiatric knowledge is questionable, transporting it or accepting it, importing it, creates a significant problem because it is not transported into a vacuum or into a clean paper, a clean space. It is actually transported to a space where there is already existing knowledge and practice. So that's one problem. Of course, our current focus is adapting and exporting psychotherapies, and we are nested in this reality. So that's one historical reality. The other is, of course, the challenge of Africa and the state of mental health care in Africa itself. So adapting psychotherapies is never going to be a copy and paste endeavor. One is, despite some American politicians believe that Africa is a country, it is not. There is no single African culture. It is in a constant process of change. And as you know, there are significant variations in engaging with one's own culture. As a result of encounter with other, we all are bound to change and individualize in that sense. And in any case, there are no unique cultures. So adopting or adapting something for the entire continent of Africa is problematic. A quick review of the literature on adopting psychotherapies in Africa context provides little to go by. And despite that, despite major efforts with adopting psychotherapy and bringing mental health care into Africa, in general, issues to mental health in Africa remains a neglected affair. So to give you some idea, as I said, despite several years of effort, there are only 1.4 mental health professionals per 100,000 population on the African continent. The global average of mental health professionals of any discipline is 9 per 100,000 population. Using another indicator of access to mental health care, the situation is not any better. In 2020, annual mental health outpatient visits in Africa were 94 per 100,000 population, whereas the global average was 2001 per 100,000 population. Mental health outpatient visits are far higher in some high-income settings. For example, in Ontario, Canada, which you are familiar with, between 2017 and 2022, the monthly rate of mental health outpatient visits was over 4,000 per 100,000 population across all specialties, and over 1,000 per 100,000 population for psychiatrists visits. The prospect for improved mental health access in Africa is further confounded by an increase in demand as a result of increased population. In addition, while supporting mental health research was one recommendation that is made several times by the WHO and other actors, with the resources invested over the past 2 decades, the amount and relevance of research that comes from the continent is still extremely limited. Those that exist primarily examine interventions for specific ailments, substance abuse, trauma, or depression, or specific modes of treatment, antidepressant, antipsychotics, psychotherapy. And lastly, very few reviews have sought to assess the extent to which interventions used in sub-Saharan Africa reflect on adapting to local cultural context. However, what we could gather out of what is available is that there have been attempts to adapt and adopt evidence-based Western models of psychotherapy. Some are simplistic in their assumptions, like an earlier paper from Nigeria, which concludes that CBT meets both the needs of the African patient to be directed and the therapist's need for brevity. Others are focused on the role and collaboration with traditional healers, and the rest on how to improve access for psychological interventions through task shifting to primary care and lay workers. My own interest in the adaptation of Western models of psychotherapies and Western knowledge in general to Ethiopia started when I was a resident in the Toronto Addis Ababa Psychiatry project known as TAAAC. Some of you are well aware of what the Toronto Addis Ababa Psychiatry project is. It was started in 2003 to train psychiatrists in Ethiopia, trained over 130 psychiatrists to date, and it opened the door for more training programs, including clinical psychology in Ethiopia. When the TAAAC program started, there was one psychiatry residency program and few faculty, 3 faculty to be specific. Now we have 4, 5 psychiatry residency training programs and a number of other programs for training clinical psychology and other mental health professionals. So that's where my journey began. When I was a first-year resident, I was given the opportunity to work as a research assistant in a large mental health project. The task was clear. It was translating and administering a research instrument. That was it. My understanding at the time was that scientific knowledge is universal and can be translated into different languages. It can be translated to different languages. Our role, my role, was to master it, know it by heart, and pass it on. As I was engaged with this process and kept learning and mastering the world of adapting instruments to local contexts, unpacking concepts of validity, content validity, construct validity, context, semantics, and so on, I thought that was it. My role was clear. A good, clean copy and paste would make development possible. Until I asked a follow-up question to a question. As a research assistant, I was administering this particular instrument in the Amharic language, in the local language. And it was a simple question of, in the past 2 weeks, have you ever felt so sad that you cried? And the answer was a yes and no. And that particular instrument did not have any further probing questions to follow up. So yes and no will follow the pattern, and then you add the numbers and you decide whether someone meets a cutoff point to decide whether they have an illness or not. And then in one of these interviews, I asked one of the participants why. And the reply came, a relative died last week and I was at the funeral. So in the Ethiopian culture, if you attend a funeral, the deceased one do not necessarily have to be a loved one for people to cry. It's part of the culture that you join loved ones and their relatives and you shed a tear when someone dies. So there was nothing pathological about this particular experience. I'm sure we all have encountered similar responses in various ways. For me, the lesson was that there are more questions to be asked, and any instrument to ascertain the validity of a concept is just the tip of the iceberg. It got me thinking. This was followed by the first psychiatry teaching trip to Addis Ababa University by the TAAAC group. The modality was interpersonal psychotherapy. I have to provide a bit of background to the context that we were talking about here. At the time, 2002, 2003, when TAAAC introduced, and 2006, when IPT was introduced, the TAAAC program, the Ethiopian population, as I said, was 77 million, and it has doubled now. There were only 3 faculty at Addis Ababa University Department of Psychiatry, and in terms of available treatment options, we only had medications, of which 3 antipsychotics, 2 antidepressants, 1 benzodiazepine, and maybe a mood stabilizer. That hasn't changed much over the last 20 years, to be honest. And the supplies for these medications could be quite unreliable. So hearing that psychotherapy was going to be introduced and that we were going to learn it was a very welcome news for all of us. IPT, of course, proved an immediate success. The relational focus was a catch. It was intuitively familiar, as Ethiopian society is fundamentally relational. The idea of suffering, symptoms, and healing as functions of social relationships hit close to home. In addition, it was manualized, it was culturally adapted for use in Uganda already, and of course, the University of Toronto teachers were great. Following the introduction of IPT in 2006, we went through various iterations of IPT for Ethiopia, through discussions, consensus meetings, and implementation research through a joint grant called the Biaber Project, which I'll talk about more, which is funded by Grant Challenge Canada. And this was followed by the introduction of other modalities of treatment, CBT, psychodynamic, and so on. So through our conversations and adaptation process in our various engagements over a period of essentially 6-7 years, we started talking about cultural adaptations. And initially, we were just looking at what is available within our culture in terms of adapting some of the theories and principles of IPT. For example, what are the cultural ways of resolving conflict between individuals? And is there already a modality to deal with that? And how do we incorporate that into the IPT models that we practice? And how do we expand the biopsychosocial model to include a sort of a cultural formulation so that we contextualized some of the presentations that our patients come up with. And the other encounter, I think in terms of background, one needs to understand when we talk about like medication treatments or psychotherapy, any form of mental health treatment, our assumption is that there is something, but we are talking here about a context where there is nothing. The idea of talking to people to help them get better is not a common, and it's not considered as part of what modern health systems should be doing. So that was part of the sort of the subcultural adaptations that we encountered. And of course, there are the practical adaptations in terms of the number of sessions, what is possible to deliver in one session and what's possible to deliver in 2 to 4 sessions, because for most Ethiopians, coming for 12, 16 sessions of therapy is logistically impossible. So as we develop these adaptations, we embarked on addressing the issue of access here, because irrespective of the number of psychiatrists we train, we know we're never going to reach the number that would address the access issue for mental health care in general and psychotherapy in particular. So the Biaber Project was funded by the Grand Challenge Canada, was led by myself, Claire Payne, Paula Ravis, Jonas Baharatibab, and others, both from Addis Ababa University and University of Toronto. We recognized the gap in the existing mental health system in Ethiopia, because it was specialty focused at the time. And when it comes to primary care, essentially there was no mental health care available at the time when we did this. So introducing just interpersonal psychotherapy was not going to cut it. So we have to address issues of mental health integration, some key principles of mental health service delivery, assessment of risk, stigma, screening, and so on. So it became a mental health integration project than a scale-up of introducing interpersonal psychotherapy that is adapted to Ethiopia. But we actually quite successfully managed to do this. And we were able to train close to 500 workers, sales professionals, some mental health professionals, very few mental health professionals, but quite a significant number of primary care workers to be able to identify, screen, and deliver interpersonal psychotherapy adapted for Ethiopia in 5 regions across Ethiopia. And in the 3 years of the project, we were able to screen and for patients, like to attend one session, 20,000 patients across 5 regions and 15 health centers, and patients treated between 2 to 4 sessions up to 1,365. So that was a huge number that we were able to reach to. So in terms of adapting a particular model and going through that process, we felt we have done some progress in that regard. But so far is the story. What are the lessons and considerations is the question. Western psychotherapy in most parts of Africa is an emerging discipline. This is both a challenge and an opportunity. It is an opportunity because once it is successfully introduced, it has the potential to be the main modality of treatment for most mental health related problems, even above and beyond medication treatments. The challenge is that in the haste to provide access to mental health services, psychotherapies will be used with minimal consideration of local needs and appropriate adaptation. So far, both the research and practice of psychotherapy has focused on questions of how to modify it, adapt it, and apply it, and on the other side, addressing the workforce challenge. However, 2 major considerations are lacking in terms of researching and adapting and adopting psychotherapies. The first gap is our tendency to neglect or downplay the fact that knowledge has been shared across cultures for millennia, often being shaped into something rather different as it is taken up in another context. In our experience with the Biaber Project, when we returned to talk to the primary care workers we trained in our project, asking how they are using IPT-E, their response was mostly about how they found that it is a way to talk to their patients and how their patients were benefiting from this new way of treatment, this therapy. In fact, they had over time devised a modification of IPT that had moved away from, deviated from what we had taught. Their therapy was successful. Instead of worrying about how to ensure close practice of the imported Western model, we need to capture through research their pragmatic change and teach this as the local form of therapy. So it's never really one or two ways. It was all interconnected. The second is, I think, one of the most significant flaws in the import or imposition of a Western psychotherapy model is a failure to examine assumptions underpinning the model's development. Western psychotherapy models were developed with a particular understanding that an individual, initially a middle-class European adult, equipped with a unique sense of agency and the money and the tools that will enable mastery over one's life. However, the African conception of a person is diametrically different, where the central organizing principle of personhood is connectedness and agency that socially equips the individual with tools that enable competence in relationships. Each model leads to different ideas about what constitutes particular forms of suffering, how they are perceived and understood, how idioms of distress are expressed, and how particular explanatory models are shaped and organized along the domain of personal, social, environmental, and spiritual relationships. On the other hand, the historical development of psychotherapy in Africa does not begin with informed understanding of collective identity or local conceptualizations of illness and treatments, but with an idea of an African mind invented and constructed by the West, the other. In this regard, there is a lot to learn about adapting and adopting between cultures. This applies to not only efforts to transpose European, North American theories, methodologies, and educational practices to other contexts, but also in bringing theories from other cultures into wider use. In the book, Transforming Medical Education, Historical Case Studies of Teaching, Learning, and Belonging in Medicine, Kujib Khan describes two medieval examples of knowledge adaptation: the uptake of Chinese and Korean medical texts in Japan and the uptake of Greco-Roman medical texts in the Islamic world. Khan notes that in each case, original medical texts were appropriated and reformulated and reworked. Texts were also incorporated into the newly emerging medical canons in those places. This led to a reorganization of imported medical knowledge in both Islamic world and medieval Japan. As a global mental health community, studies of other efforts to export or import mental health knowledge could advance understanding of these processes. In the end, despite the tendency of our time to polarize, there is so much need in the world that the meeting of two cultures is inevitable one way or another. Either to dominate, to fight, or collaborate, the encounter is going to change both in more ways than intended. When we returned to talk to our primary care workers, here are some of the responses we got. So one primary care worker said, "We have many cases, and this is the first mental health training for primary care workers. We did not know how to solve problems for our patients. This supports us to help patients without medications. It helps them economically with their work. They talk to us and get better without medications. Another one has said it has changed our lives and perspectives on helping others. It makes you more relevant and wanted in the system. We recognize patients who are shopping for care at health centers, private clinics, holy waters, places, and now we can offer IPT-E. They are physically symptomatic and come less. They need fewer services. We are seeing an increase in young people admitting they have problems. Another one. And this is from a patient. No professional have asked me these questions. Thank you. You have seen my soul. Thank you. A patient who was going to divorce his wife was able to amend their marriage after IPT-E. He brought her to the clinic to say thank you. This is from another primary care worker. So the encounter is not a bad thing, but it needs cautious process of adaptation. I think going forward, the kind of research that we would like to focus on and we may need to focus on is one, interrogating foundational assumptions of various models. I think what happened over the years in terms of mental health service development globally is the access problem dominated so much that we started to forget that the established models and established knowledge, psychiatric knowledge itself is open for questioning. And we don't see that kind of research now being done as much. We focus more and more on how access is possible and in what form. And the other is, of course, healing occurs. I think Drake Summerfield says healing occurs in our social institutions. There are healing systems that are not Western, and they have existed for centuries, and people are using them, people are preferring them. In some places, way more than they would prefer modern quote-unquote mental health services. So exploring those models and those existing social institutions and how they impact healing would be another direction to focus on. And of course, the mechanism of action and psychotherapy process that is happening naturally in terms of really changing a particular model, even when we wanted to, we focus on fidelity to a particular model and we wanted to stay. That would be the kind of direction I think it is bound to be affected and changed with the encounter, and that's what requires capturing in research. And of course, as I said, exploring other forms of knowing and knowledge and its relevance for our collective development. I think when we talk about adaptation, what we forget to talk about is that would the adapted model could be readapted to its origin? That's a kind of question. When we talk about mutually learning from each other, say what can be learned from these existing knowledge systems and base globally is also another question that we need to focus on. I would like to conclude by this quote from an Ethiopian playwright in 1950, Mengistu Lemma, in a debate about what kind of development Ethiopia should follow. He wrote, as a principle of cultural development, the preservation of the best from the past is as relevant as adopting the best from the present. But I think I will modify the only word past here. I think the best from everyone is as relevant, and look like not dismissing knowledge because we don't know it, And that's where we need to be a bit careful and be open and committed to embracing the whole idea of diversity, diverse knowledge, and knowledge systems. Thank you very much for your attention.
Dawit, thank you. This is a wonderful, thought-provoking lecture, and I really appreciate you coming and sharing with us and our audience as well. And beyond that, it's so nice to see you again with your connections with the Addis Ababa project, the University of Toronto, and that connection. As many have said, that you were some of them remember you as their first chief resident many years ago, when that program has been so successful in capacity building and developing, particularly in Ethiopia. And there's some wonderful questions from the audience as well. There's a question from Dr. Jack Haggerty from North, one of our leaders there, psychiatry leaders, and his question was, have there been efforts to adapt the DSM type of construct to such as interpreting psychosis in the African context? Is there some type of parallel model similar to the DSM that has happened in in Ethiopia or other nations in Africa? So his experience in Rwanda, Nigeria, is that the DSM doesn't always serve the population. It's too narrow there, right? So
I can add my own experience, and our experience with the DSM is as problematic as he mentioned, and sadly, to my knowledge, there has been no effort to come up with a kind of classification that would fit into the local context and the way society is organized. When we looked at an earlier study in Ethiopia, our colleagues Atala Alam and Masfan Araya explored local ways of identifying different disorders. I'm not going to confuse you by listing them in Amharic, but what they found is, again, categories, not as many as 300 something in DSM-5, but quite concise, but clearly distinct categories. They were able to identify those. But as you know, in most parts of Africa, including Ethiopia, the West is taken as the standard measure, unfortunately. And as a result, bringing in this knowledge is not an easy task. And the kind of research that dominated the continent over the years is actually pushing the same sort of dominant views as universal, and it is a challenge. But certainly in Ethiopia, but in most, again, I'm sure in most parts of Africa as well, at least where I have been, there are local ways of identifying and categorizing mental illnesses, but they have not been part of mainstream, not mainstream, but modern mental health service development.
Absolutely. There's lots of feedback that they really liked your presentation. There's a question following that about, can you talk about how spirituality and religion can work with psychotherapy in the African context? Particularly, they're asking about Ethiopia from your experience.
Absolutely. I think I can talk. I can give a lecture on that because that's what we, myself and my colleague Dr. Jonas Baharatova and our colleague Sam Lowe, Lisa Anderman, another colleague from our department, do a lot of research and publish on how to bring in spiritual healing systems and our care together. And we find a lot of knowledge, and also actually get surprised by some of the knowledge that we get from engaging with, for example, holy water administering priestess. We had this focus group discussion. The purpose was to ask, for us to say what we do, to share what we do and how we do it, and for them to tell us what they do and how they do it and why they think that it works. And I have asked a question like, very simple question, like why do you think this is why we think our treatment works? Why do you think your treatment works? And one priest stood up and said, it's very easy. We provide people three things. One, we provide them with hope, he said. And then the other is we encourage them to persevere and stay in the process, believe in the process. And then the third is faith and believing in whatever spiritual commitment that people have. And it was a surprise because for us, we have to go through medical school and 3 years of psychiatry and a bit of psychotherapy training to learn that instilling hope is a very important component of why psychotherapy and psychiatric engagement works, and the whole idea of perseverance. And another is what makes it easy and possible for people to accept these healing systems, but struggle to accept our health system, like the sort of modern mental health services for people. And again, they provide us with so many other forms of knowledge and experiences that help them keep their patients engaged with the system. And there is quite a bit to learn from that angle, because at the end of the day, spirituality and that relationship is a very important part of what a person is in the African and Ethiopian context.
Thank you, Dawit. That's a very, very comprehensive answer. Dr. Paula Ravitz has a question. I mean, she really gave some really good feedback about all the things that you mentioned. Her question was, can you say a little bit more about how nurses have adapted IPT-E, to their context, and how that's been done from your experience?
Dr. Paula Ravitz is involved with this work quite a lot. So one sort of adaptation is, on top of my head, I need to go back to the data to be very specific, is actually developing tools of communication in their own ways, with their own understanding of, let's say, in IPT, we talk about the interpersonal circle. And when they found that to be a bit complex for patients to engage with, they design their own diagrams and models and to identify and work with their patients. But I'm sure if I had the time, I would come up with more specific answers for Paula.
Wonderful. There's a question here about, do you think the introduction of psychiatry in Ethiopia has received well by the local healers? What can we learn from the local healers? Similar question.
Yeah. Initially, of course, there is a hesitation, as always, and the skepticism and suspiciousness attached with Western models of treatment in general, not only with psychiatry, to be honest, but with all forms of healthcare. It all has to do with, one is the first encounter. The first encounter with the West was not ideal, so to say. Let's put it that way, and that has triggered a pattern of attitude towards Western medicine that it needs to be considered with utmost care and suspicion. That's the framework.
Mm-hmm.
And when it comes to mental health practice in particular, I think the way Western psychiatric explanatory models in terms of the biopsychosocial model, the biological, even the psychological and social cause of mental illness are still very far from the explanatory models that people harbor in terms of understanding their sufferings. So that disconnect creates a problem of trust between practitioners. So if people don't consider it with suspicion, and the healers also see it in that way, and it doesn't fit into their own mode of thinking and understanding. I think one of the ways we try to address this particular challenge is engagement. We as I was saying about the encounter between the Western models and non-Western models, but even within the non-Western context, our engagement with our own people needs that exploration, because in a way, I speak in English, I understand these things in English, and so I am an Ethiopian, but for all intents and purposes, I am a Western trained psychiatrist, and my ideas are alien to myself and also to the people that I serve. So engagement, we have found that we have published on this again on transformative learning with the our colleagues. Sophie from the Department of Psychiatry, Addis, Cynthia Whitehead, and Tina Martini with them about how our engagement with traditional healers really end up in transforming our engagement. So it is workable, but the encounter engagement is very important.
Yeah, we're going to go a little bit longer because this is the future of psychotherapy. So I know some of the other people may have to leave our regular Grand Rounds people. There's a question from Dr. Farooq Naeem, who's also kind of an expert in culturally adapted psychotherapy in the South Asian context in particular. And his question was about, have you tried adapting CBT, which has some strong evidence in both the West and East?
Yes, we've tried to adopt CBT. Actually, one of our colleagues had a project on adapting CBT. But to be honest, the appeal of CBT for our patients was not as high as it was for IPT. We didn't do a large scale adaptation as we did with IPT, but with a small scale attempt, it can be done. And interestingly, it has uptake among probably educated, internet-friendly patient base, but a large-scale adaptation is not done, and eventually, I'm sure that will be one thing we'll be looking at.
Yeah, thank you. I know there's some other questions as well. I mean, if there are other questions, you can always reach out to Anne-Marie Rezwan, and she will connect with Dawit to answer those questions. So thank you for being here today. I think the slides will be available. Dawit will give us the slides that we can give it to some people, because I know they've asked if we could have a look at them, and we'll follow up on that. If you have other questions, Anne-Marie, connect with Anne-Marie and she will help with that. So thank you again, Dawit, for this especially this special lecture, the Mary Seeman Memorial Lecture, and in light of all the everything that's happened this week. Thank you, and I think it was a wonderful, thoughtful lecture, very thought-provoking, and we really appreciate it on behalf of the planning committee. And just to let everyone know, the future of psychotherapy, folks, that you have it on your email for the 2 different workshops. One by Dr. Holly Schwartz and the other one by Dr. Paula Ravitz and John Hunter. I really want to thank them for doing the workshop as well. So please use those links. If you have any questions or query, email Anne-Marie and she will, troubleshoot that for you. So thank you, everyone. And we'll see you for our grand rounds. People, thank you for joining today, and we'll see you next month in our next grand round. So thank you. Take care.